My name is Donna Dittman Hale, and I'm happy to welcome all of you on behalf of Bay Rivers Telehealth Alliance. This webinar series is also being sponsored by the Virginia Opioid Abatement Authority, and they were unable to join us this morning because they're all down at the Virginia Sheriff's Association meeting in Virginia Beach. But they send their regards, and also just a reminder, if any cities or counties are interested in applying for funding from the Virginia Opioid Abatement Authority, their next deadline coming up is on April 1st. So get your proposals in. We will be next on our next session in April 24th. We will be featuring the question, how do I pay for this? And one of our speakers will be Tony McDowell from the Virginia Opioid Abatement Authority. We'll also have Michelle White from the Department of Justice, who will be talking about national sources of funding. And I'll also be sharing with you some information on collaborative grant making, working together to get the funding you need to implement these programs. If you haven't registered for that session separately, please do so. We'd love to have you join us. And we will be sending out additional information to those of you who have registered with information about our newest speaker to join our lineup. So we're very excited about that session. We are also very excited about today's session featuring the Fairfax County Sheriff's Department and their amazing programs up there. And just a few reminders before I turn the program over to the staff at the Fairfax County Sheriff's Department. We will be using the Q&A function for any of your questions. And we'll take a break at around 10:15, something like that. So if you have questions, we'll start with Laura Yeager and Sheriff Kincaid. And then we'll have a break, and then we'll have a second session with Laura and Sahana Kapoor on the second half of the morning. So please use the Q&A for your questions. And the other thing I wanted to ask you is in the chat, we do have a link to a participant information survey, and that is to collect some information that we did not collect in your registration, just about what your role is in your organization, and if you have other ideas for additional webinars. So if you can take a few minutes either now or during the break to complete that quick survey, we'd appreciate it. And we'll keep putting it in the chat, because I know if it was put in there before you came on, you probably aren't seeing it yet. We do have your cameras and your mutes and the chat disabled, because it's just a lot for us to try to monitor the chat and the Q&A. So if you're having any concerns, feel free to put that in the Q&A. I think that's all my housekeeping details. So let me get us started with the real nuts and bolts of implementing effective and jail-based recovery initiatives. We're so delighted to have Laura Yeager and Sheriff Kincaid and Sahana Kapoor here today. So I'm going to turn it over to Laura to get this party started. Thank you. Laura, you're muted. We don't want to miss a single word.
Good morning, everybody. I was doing a brilliant welcome, but sorry it was muted. We're really happy to be here with you today, and thanks to the Alliance and to the Opioid Abatement Authority for hosting. This slide is just a quick overview of the topics we'll be covering today. A few pointers. We tend to use MAT, and we call that medication for addiction treatment, and MOUD, medications for opioid use disorder, interchangeably. So you will hear us talking today using those terms, and know that they're both are acceptable at this time. MOUD is a little bit more current. As we go through our process and what we've done today to implement our jail-based treatment and recovery services, know and recognize that there is no one way to implement these programs anywhere. So as you're listening to us talk about what we've done, it's not a one-size-all opportunity here. So take from us what might be helpful to you, but also do what works in your own community. We're thrilled to be here. The work that we've been able to do in Fairfax County wouldn't be possible without the leadership of our sheriff, who has just been so helpful in moving us and evolving our services forward. She's the reason we're successful. Sahana and I are really thrilled to be able to present with her today. At this time, I want to welcome Sheriff Kincaid. She will be providing us background about our community and about our adult detention center. And she'll also provide you with a big picture of why we do what we do. So I want to welcome Sheriff Stacy Kincaid. Thank you, Sahana. Good morning, everyone. Okay. Good morning. As you heard from Laura, we're very happy to be here today and to share with you what we've been doing for the past several years. I'd like to just give a little bit of history. Studying behavioral health, studying opioid use disorder, and working with the sheriff's office for over 36 years. I can't necessarily say that I'm an expert, but what I can tell you is that we're pretty darn close to being experts in this field. The way that it used to be when someone would come into jail, it was, you lock somebody up, you throw away the key. That is completely out of our protocol, our process. We believe that there's always an opportunity to help somebody. So we take what we're doing very seriously, and we're very happy to share it. So I'm just going to begin with the first slide and just share with you, just some facts about Fairfax County. We are an urban suburb within the Washington, D.C. area. Our county is 417 square miles, about the same size as the state of Delaware. We also have a high population of approximately 1.2 million people. And while Fairfax County is just around 1% of Virginia's land, our county has 25% of Virginia's total population. We have a highly diverse and multilingual community, and over 38% of our households speak a language other than English at home. We also have a high socioeconomic levels, but we also have pockets of deep poverty. So it's important to note that we see opioid use disorder spanning all ages, races, and walks of life. It is also an equal opportunity chronic illness. Next slide. Okay, so a little bit about our adult detention center, and these numbers are from FY23. We have a capacity to hold about 1,200, a little over 1,200 individuals. Our daily average population runs between 650, 670. For a comparison, in FY 2014, the year I took office, our ADP was 1,233. Many factors have contributed to the population decline, specifically the robust inmate programs that we have, certainly our countywide Diversion First program, and beginning, obviously, we can all remember in FY 2020, the start of the global pandemic. So as you can see from the slide, the average length of stay for males is higher, it's 31 days, females 10 days, and then the majority age range is between 18 to 38 years old. We have many individuals with opioid use disorder who have not experienced the concept of recovery. Although we have folks that are not in here for an extended period of time, we know that by providing MOUD treatment and making community clinic referrals, we can change the trajectory of individual lives. So we are accredited by the Virginia Law Enforcement Professional Standards Commission, the American Correctional Association, the Virginia Department of Corrections, and National Commission on Correctional Health Care. I'm very proud of these accreditations. These 4 independent bodies govern the health, safety, and operational standards. 3 out of the 4 are voluntary processes in which we participate. The Virginia Department of Corrections is the only accreditation process that is mandated. The reason why we do this and participate is that it helps us demonstrate that we are adhering to the highest national and state standards of excellence. It also ensures that we provide safe, secure, and high quality care in the adult detention center, and it assesses our strengths as well as opportunities for improvement. It validates our implementation of state-of-the-art policies, practices, and procedures, as well as specific guidelines for our daily operations. And accreditation helps us achieve the highest level of professionalism and staff morale. We consistently strive to improve our practices, and if you're interested in learning more about the accreditation process, we can connect you with our accreditation manager. Okay, so a little bit of the history about how we got to where we, from how we are where we are right now. These programs were, as you can see, developed and have grown even through the global pandemic. So this slide highlights key milestones of our efforts in the Adult Detention Center and the community. And what we're doing is focusing on outcomes for people with substance use disorders and/or mental illness. In 2016, Diversion First, which is a countywide initiative, was launched. And what Diversion First does is it diverts people from justice system involvement to assessment, treatment, and recovery efforts. From that, we moved on, and kind of like under the umbrella was our STAR program. STAR means Striving to Achieve Recovery. That was established in the Adult Detention Center for individuals that would not be eligible for diversion. Our program is authentic, holistic, peer-based program for individuals with substance use disorders. One of the most important things we recognize and we pay attention to and we focus on is underlying trauma. This program restores dignity, and with support from my deputies, medical staff, and jail-based community services board clinicians, and our community partners, STAR is a statewide and nationally recognized recovery-focused program. I have to give a shout out. I don't know if Sheriff Carl Leonard from Chesterfield is participating in the seminar, but we, back, I guess, in 2017, traveled to Chesterfield many times to learn about their HEART program. So we took what worked with them and what would work for us without having to reinvent the wheel, and we created our STAR program. But big shout out to Sheriff Carl Leonard and his staff. In 2020, we implemented our Medication for Addiction Treatment Program, otherwise known as MAT, and that was launched as a Sheriff's Office primary intervention to combat the opioid epidemic. Our goals, simple, to eliminate stigma, reduce overdoses, and recidivism. We believe that jails provide an opportunity for growth and change. Now, you just heard what I said. We believe that jails provide an opportunity for growth and change. You never really hear that too much, but this is what we do, and this is our philosophy. We want people to leave our jail healthier and safer than when they arrived. We have prioritized jail-based MAT as our key response to address the opioid crisis in our community and across the country. We will, throughout this webinar, we plan on going into more depth on our efforts based on this philosophy. Next slide. Okay, so we know that our jail-based services can reduce recidivism, and our jail-based services reduce overdoses and recidivism. From this slide, this is a look at the drug addiction and relapse rates of our other chronic illnesses, and we provide medical care for all of these. We see better and faster outcomes treating opioid use disorder than any other chronic illness. We talk about chronic, we talk about having a continuing illness for a long time and constantly reoccurring and difficult to eradicate. It requires medical attention or limits daily life activities. leading causes of death and disabilities. And this information comes from the CDC. Jails are mandated to treat chronic illness. Back when I first started, when someone would come in and they were withdrawing, during that time, we just treated the symptoms, not the addiction. So as you can see, the Supreme Court in 1976 found that depriving healthcare to incarcerated individuals is a violation of the Eighth Amendment, which is focused on cruel and unusual punishment. And substance use disorders are chronic illnesses requiring prioritization by correctional healthcare providers. Our MAP program is managed by our medical providers, county staff, and some contractors, and they provide opioid use disorder treatment. The chronic mandate resides with the sheriff's office, and we provide care 24/7. And recognition of opioid use disorder as a chronic illness has challenged all of us, resulting in a huge culture shift in our organization. Not only with us, my staff, my sworn staff, but also with my medical staff. We work to challenge stigma and assumptions around substance use disorders. We help people to understand that addiction is a chronic illness. And as I mentioned, all staff have been challenged by this, including sworn and medical providers. Stigma is real, and you have to address it to have a solid MAP program. Collaboration. We cannot do this on our own, and anybody that's tried will realize that they can't do it either. So you can see some of our partners listed. Excuse me, let me some water. So as we share with you today, we'll be mentioning our partners in this effort, and you will hear more about them throughout the webinar. The Fairfax County Falls Church Community Services Board has behavioral health and certified peer recovery staff in the community and in our adult detention center. They provide counseling, education, and support to help address behavioral health issues, and also support services for individuals with developmental disabilities. The Chris Atwood Foundation is a community nonprofit agency that is peer run and operated. They also have dedicated office space in our adult detention center, and they work with individuals with substance use disorders. George Mason University has launched a bridge clinic program for individuals with opioid use disorder who are rapidly released, ambivalent, or not fully engaged in CSB services. We also launched our own services with a grant from the Washington-Baltimore HIDA, and we are very grateful for their support. We work closely with Fairfax County Opioid and Substance Use Task Force on strategy and being part of the larger Fairfax County efforts. We also just received county direct distribution settlement funds that we are enhancing through our MAT efforts. And we are grateful, even though they're not on this call, to the Virginia Opioid Abatement Authority for their statewide strategy, funding, and sponsorship of this webinar, as you heard earlier. They are truly a great partner. So the next slide, Striving to Achieve Recovery Program. Very, very proud of this program. In fact, actually borrowed 2 inmates to begin this program from Chesterfield County. This is a recovery program that focuses on substance use disorder, but also includes alcoholism, and this program is housed, it's in a small therapeutic community environment. So this, again, as you heard, was adapted from the HARP program. This is a voluntary program that is a separate housing area. It's highly structured, very highly structured, and focused on growth and recovery. We partner with the Community Services Board, peer support specialists who facilitate the program. So by being peer-led and having folks with lived experiences really has made a tremendous difference. Not everyone being treated for opioid use disorder is in our STAR program, and not every STAR participant is on MAT. STAR is a program, and MAT is treatment for chronic illness. Our individuals are screened at booking for opioid use disorder and can be referred to the MAT program shortly thereafter. The STAR program requires inmates to voluntarily apply for the program. They have to be pre-screened, and they participate in an interview panel. Because of the type of housing environment in which they live, there are eligibility restrictions. So in addition to having a substance use disorder, they must have no current or past sex crimes or gang affiliations. Also, they must have a positive jail adjustment within the last 60 days of their stay. I want to point out that judges have requested that this program be used as a sentencing tool. And what we find is that we don't want this program just to be a check the box program. We want this program to be truly something that individuals are ready to begin and start their recovery. So just to add to that. Okay, so there are 3 phases to our STAR program. As you can see, the community is open-ended with individuals starting and completing different phases of the programming at different times. In all these phases, they focus on the whole person, including mental, spiritual, and physical concepts. Phase 1 is very structured. It includes the Living in Balance curriculum and a trauma focus, which is called Male Trauma Recovery Empowerment Model, otherwise known as MTREM. Phase 2 is where they develop altruism. They support the community and give back. This includes opportunities to receive certified peer specialist training, co-leading activities, and deepening of recovery concepts. Phase 3, that's a focus on developing a plan for community reentry and personalized plan for a sustainable future of recovery. If you were at last month's webinar, you heard Carrie Rhodes passionately talk about their family program. Our monthly family program is a facilitated program focused on rebuilding healthy relationships with loved ones. It is so important and it's very challenging. It also helps family members see their loved ones in new ways. Also, this program requires a lot of coordination with security and because of the safety and security of our facility. But we also believe it's important and rewarding component of STAR. Family members come to the unit and sit right next to their loved ones. All facets of this program draw from cognitive behavioral, experiential, and 12-step approaches. The pictures provide real examples of recovery-focused activities and opportunities that are provided to include peer support, yoga, music, into work, and certification ceremonies at the end of every phase to celebrate the successful completion of each phase. Next slide. So trauma-informed care. A large portion of the men and women who are incarcerated have experienced trauma, and the rate of PTSD is higher with these populations compared to the general public. For some individuals, a corrections environment contribute to re-traumatization, and jails and prisons implementing trauma-informed practices can help minimize the re-traumatization. As I previously mentioned, participants in STAR get to participate in the Male Trauma Recovery Empowerment Model, or MTREM. It's a psychoeducational and skills-oriented group that is gender-specific trauma group. MTREM focuses on men who have experienced many types of violence, direct exposure to physical, sexual, and emotional abuse. MTREM also can help people who are witnesses to violence and other traumatic events. We recognize that incarcerated individuals that have experienced trauma are highly vulnerable to addictive behaviors. So by implementing practices and programming that are trauma-informed, we help them to cope with their trauma symptoms, and we also nurture their overall well-being. Okay, our STAR outcomes, program outcomes. So as you can see from the screen, over the past 5 years, our success rate with our participants is 60%. Success meaning they have not returned to the community or they've returned to the community, but have not recidivated. So this picture with myself, this is Julio. Julio was a STAR participant for 22 months, starting a month after his program launched in 2018. So he says he flew from his home in California at his own expense and to talk to STAR participants. 2.5 years after his release, he is happily married, has a job, he enjoys and attends AA and or NA meetings 3 times a week. Positive affirmation from his peers has helped him to work, to keep working the program. Coming to the Adult Detention Center to speak with current STAR program participants was a final item on his jailhouse checklist. One thing I can tell you about Julio, I remember meeting him, and I remember us having a discussion about, when seeing ads on the television to drink responsibly, as many people see, especially during the Super Bowl. Well, Julio was, he had a severe problem with alcohol. And when he drank, he got very violent. So the work that he was able to do, the program that he was able to complete, plus bringing his family back into the fold. His mother had been estranged. His mother was deathly afraid of him. And when we had family night, I'll never forget her coming up and just with tears in her eyes that this is my son. I've never seen him like this. You have truly saved his life. So anyway, that's just a really good success story. And we really offer the opportunity for those that have been in this program, who have graduated from the program, to come back, because I think they become very inspirational to those individuals that are still in the program. And if I can do it, then you can do it. That's the mindset. So, and he stays in touch with us. So that's even another bonus, or he'll come in through a Teams meeting during training. So these are some quotes, that come directly from our participants. They have no problem telling us when something's not right, but certainly we appreciate when we do get some good feedback. And as you can see, one of his quotes, I take the same pride as Sheriff Kincaid when I talk about the STAR program. She's doing her part from the inside, and I'm doing my part on the outside. She's doing her part from the outside, and I'm doing my part on the inside. Not enough coffee, sorry about that. And then, of course, Carl, who is also a graduate from our program. I've been learning through STAR that recovery is taken one day at a time, baby steps, and I've been given many, many tools to stay sober tomorrow. So again, we offer hope to people who have lost their hope, and help deepen the focus on the recovery. We at the Sheriff's Office, we gain inspiration in hearing from them. And the participants and graduates also provide testimony to help tell the STAR story beyond, statistics. So that's pretty much it in a nutshell. Again, I appreciate the very nice words from Laura Yeager. I can tell you that my staff, those are the heroes. Those are the heroes. Those are the ones, my staff, my medical staff, certainly are partners, stakeholders that really are behind the great work that we do and help make us the best that we can be. So that is pretty quick, actually.
Sheriff Kincaid, we do have a couple of questions in the Q&A.
Okay.
One question: if an inmate is incarcerated less than the amount of time that it takes to go through the 3 phases of the STAR program, are they still eligible to receive medication for opioid use disorder?
So I'm sorry, I missed part of that. What did you say?
If an inmate is incarcerated less than the amount of time that it takes to go through the 3 phases of STAR,
Yes.
are they still eligible to receive medication for opioid use disorder?
Yes, they are. We have another housing location, which is we call it our MAT housing unit. So folks that may not fit the criteria to be part of the STAR program, they can be in the MAT program. So the answer is yes.
Do you know if Henrico has a program like this?
Do I know? They have a program. I know that they're doing, they have a program. I'm not 100% sure, but what's that? Oh, okay. Sheriff Gregory from Henrico, she would know. I'm sorry, I don't know the answer to that.
Thank you. Another question: And do these places have relationships to refer to when getting out of jail?
So we have, thank you for that question. That's a good question. We have a very robust reentry section within our agency. So it's complete wraparound services. When an individual gets out of jail, they leave with a backpack that's provided by the Community Services Board that has necessary items when someone gets out of jail, some toiletries. We give them a phone. We also, if they need a ride to continue on, well, when they get out and they're on our STAR program, they're going to continue in whether it's outpatient or whatever it might be. But we connect them to the Community Services Board and make sure that they're able to get to where they need to be. Also, providing a soft handoff. So if they've got a sponsor or somebody that's going to help them once they are released.
That's great. Fairfax County is a wealthy county. How can less wealthy counties implement the type of program that you run?
Good question. We hear that a lot. I can tell you that the funding that we have received, none of it's come from the county. I say that it's come from HIDA, and certainly, hopefully with, the distribution from the opioid settlement, maybe we'll see those funds. But I can tell you that we work with what we have. We have a very tight budget, and we're just fortunate with our stakeholders to be able to work together as a team. We also use, visual aids. We have programs. We're going to cover that in later on in the webinar. So I don't want to steal anybody else's thunder, but we'll cover that later.
Thank you. Next question. So I am a little out of my wheelhouse, but what is the sentencing requirement to participate in STAR?
There is no sentencing requirement. It doesn't matter if, somebody is pre-sentence, post, whether it's a misdemeanor or felony, there's absolutely no sentencing requirement. Now, certainly, if somebody comes in and maybe they have, I don't know, 2 months, we'll take somebody so they can start the recovery process whenever.
That's great. So the MAT program and STAR program are housed separately?
They are. We have protocols. Again, when we are MAT, they're housed completely separate. And yeah.
The next statement, I am the program manager for Henrico County Sheriff's Office under Sheriff Gregory. We have the RISE program and
That's right.
MAT program. So
Awesome.
that helps with the earlier program questions. The next one, in the MAT program, is there curriculum or schedule?
So they have a schedule that they go by. The curriculum is comes from the CSB, the Community Services Board. They develop the curriculum along with our staff as well. So we will talk more about that further in the webinar.
Thank you. Sheriff Kincaid, would you share the interview process for your selection of participants into the STAR program?
Sure. So the interview, first of all, one has to apply in order to get in the program. Then we've got staff members from our program section, reentry section, as well as behavioral health, who sit on a panel and ask a series of questions. So they just, that's how they, it's very basic, but certainly to get a little bit of history from the person to really determine whether or not the person is interested. But, even there are times when, we're not going to have somebody not come into the program because they don't say the, the buzzwords or what have you, but it's a process. And generally the folks that come and they ask questions. Some decide not to be in it because, they want to use it as a sentencing, alternative, or they want to get good time for it, and none of that's offered. but it's a good process. And the other part of this program is the accountability piece. Since you brought that up about the interview piece, they hold one another accountable. The deputy that's in the housing unit, the deputy's there for the security of it. And but they're the ones who, I mean, if somebody's not pulling their weight, doing what they're expected to do, then of course they can be removed from the program.
Thank you. I'm going to skip a couple of questions. This next one kind of ties into that. Is there any consequence if the person does not follow through on the program?
The consequence? Well, we believe in second chances and third chances. And, you know, if it gets to the point where the participant is not participating, then they're removed from the program and placed back in general population.
Thank you. Do you offer tours of the MAT and STAR programs to other sheriff departments?
All the time. Please
Great.
feel free to, you know, come visit us. We're an open book. We'll share, we'll give you what we have, what we do. There's no secrets, and we're happy to share.
How many participants do you have on Suboxone, Vivitrol, Methadone total between MAT and STAR pods?
How many? I think we have 100 on Suboxone. Methadone, we do not distribute, we do not dispense unless we have a pregnant female that is, you know, has opioid use disorder. And Sublocade, we love to be able to give Sublocade because you can't really divert Sublocade. The injection is very expensive, and although we're working with some legislators to try and see about getting the cost cut. And more of that will be covered as well.
Thank you. What about if you are an outpatient program? Do you offer tours for them also?
Are you asking if somebody's in an outpatient program, do we offer them tours?
All right, she just clarified. I did not mean tours, but do you meet with the staff that work in the program?
We do. We do. As a matter of fact, I just met with them 2-3 weeks ago. I'm sure some of them are on the webinar, but yeah, we do meet. It's important that we, you know, the whole communication piece, because as we know, it makes us or breaks us. So we do take opportunities to meet, and we don't just meet to meet. There's always something that we talk about, how we can improve upon things. So very critically important to maintain those open lines of communication.
What do you do about patients that come in on methadone that are not pregnant?
We'll cover that further on in the webinar.
Thank you. And we have time for a few more questions. If anybody has something they'd like to drop in the Q&A.
I have a question, and I can't drop things in the Q&A. I was curious about, I noticed that your STAR program focuses on men. Do you have a comparable program for women? Or you
So thank you for asking. I'm an equal opportunist. So of course, we are putting together a STAR program for the women. Certainly not an excuse that our female population is much lower than our male population. But we are currently working on that. We do have folks that from the Chris Atwood Foundation, from the Community Services Board, that work with our females as well as our staff. But we do have women on that. Yeah, we do have women on that. We just are starting to create the STAR program for the women.
Thank you. And being a telehealth organization, we're always curious about if you all use telehealth for some of your delivery of some of your health and counseling services.
A little bit. So we do, I mean, if, for example, someone needs, I mean, if we need assistance, we need a psychiatrist, we need a doc to talk to a patient, we will use that, but pretty much, you know, everything's done on site.
Yeah. I noticed that we do have one other question showing up in the Q&A section. Do you have any suggestions if the CSB personnel in my area are against using MAT as a treatment?
That's a great question. I'll be the first one to tell you that when we started the discussion about MAT, I was very much against it because my thought process was that why are we giving a drug, to continue this, addiction? After lots of research, after speaking with many people who are the experts in the field, after speaking with my staff, I changed my mind. And again, I like to think that I'm very open, but again, it's changing the mindset and showing people that it actually works. And I would say that if somebody's CSB is completely against it, I think that there's an opportunity for, certainly with our CSB, to maybe connect and talk about the benefits and, again, come up and take a tour and learn how things can work. I know people are concerned sometimes about the diversion of MAT, but I can tell you that we have a protocol, we have a policy. It's, handing out Suboxone. It's not just, okay, here it is, and then you walk away. It's a very intensive process in dispensing Suboxone.
Thank you. And another question, can you share in the resources or in an email more about the MTREM model you are using?
I'm going to let the experts do that, and you'll hear from Laura and Sahana more in the seminar. They're going to review it, talk about it more.
Thank you. Yes, we have both Sahana and Laura here. Thank you so much, Sheriff Kincaid, for all your amazing work. We really appreciate you and your leadership in the state and nationally in establishing and supporting these programs, the development of them in other correctional institutions. Looks like we have one more question.
Okay.
And I think maybe this is one for the next step, but the question is, why can't the inmates in the STAR program be on Suboxone?
We can. So in our STAR program, yeah, they can be on Suboxone. They can be on the MAT protocol program.
Okay, well, thank you again so much for taking your time out of your busy day. We really appreciate it. And I think we're going to wait to take a break and maybe get started into, is it to Sahana for the next section of?
Laura.
Laura, okay, back to Laura.
Okay.
Thank you so much.
Thank you.
And we'll have a break at about 10:15. So thank you, Laura, for the
The sheriff was right on. Many of your questions were awesome questions, and Sahana and I will be using those questions to try to guide some of our presentation. Many of the questions you asked are included in what we're going to talk about, but feel free to ask again at the end if we haven't clarified enough for you. A lot of what we have discovered in our own process of introducing recovery focused programs and medications for addiction treatment in our adult detention center are really about change. It's about systems change. It's about individual change. And I think as human beings, we tend to be, I can speak for myself, naturally resistant to doing something new or to changing because we're so used to doing things as they are. So as we have gone forward, I reflect a lot on, so people in behavioral health will probably be very familiar with Prochaska and DiClemente's stages of change model. And I like to think of this model, and I'll review it very quickly, but as not just about individual change, but about systems change. So these guys developed this model really about tobacco cessation, and it's sort of the cycle of individual change. Again, it applies to our system as well. in this model, it fits any kind of behavioral change, right? If you want to lose weight, if you want to stop drinking, if you want to stop smoking, if you want to live a healthier lifestyle, we tend to all follow this cycle based on research. I like to use evidence-based and have theoretical models that have been proven to be effective when we look at doing systems change, because it legitimizes what we're doing. But a quick look at the stages of change here is like pre-contemplation. And for those of you in your communities, I think you could probably recognize individuals and your own systems or organizations within these stages. You know, pre-contemplation is when people may not even be recognizing there's an issue or the consequences of their own actions, like around smoking or eating that extra bonbon, and when you're trying to lose weight. Contemplation is when we start to recognize that there is a problem or that we do want to make a change, but we may not know how to step forward. In systems, we can get mired in process, like planning, but moving to implementation can be a real challenge. I hope this resonates for some of you. It certainly has been our experience. The preparation phase is when people are willing to make tiny steps forward toward the change. You know, as we developed our MAT program, we did a lot of planning, and we got stuck there in the preparation phase at times. Then we move into action. So any individual change or systems change, there's an action phase. We're starting to step by step to change things. And we'll talk today about how we changed our SOPs, how we changed our medical practices, how we changed our booking process to be able to implement this. Then once we get that down, which is a bit of a process, is maintenance, and that's kind of staying the course, keep going forward. But as with any change, relapse occurs. It's hard to maintain the change. If we're people trying to lose weight, it's hard to maintain a weight loss because there's so many great things we want to eat out there. With MAT, things happen. We have, and we'll talk about some of the problems we've had that make you want to just go backwards and say, this isn't going to work in a jail. But we recognize this is part of the change process. And really amazingly, our sheriff, who you heard from, has never looked at stopping anything in some of the challenges we've faced in this change. So why am I telling you all this about this model? You know, in your own community or with the people you work with, it's about readiness. So if you're dealing with, I'm going to make it up, a sheriff who may not be interested, or one of your questions, a CSB who doesn't believe in MAT, implementing a program without meeting them at the stage they're in, if they don't recognize there's a problem, or they are just starting to recognize it, but they don't want to do it, coming at them with a full parade, moving forward with a program isn't going to work. It requires education. So you have to sort of plan your interventions at the same level. A lot of people, individuals with addiction issues or staff, can be ambivalent, they can lack motivation, and looking at this through the lens of this model can be very helpful. It's if you're working with individuals and you're going, they need a long-term residential treatment program, but they're still in contemplation, it's not going to be successful. You know, putting someone in an area that isn't where they're ready for isn't going to work. So I hope that you keep this in mind during our presentation and kind of moving forward to recognize that this is a natural cycle of change. Next slide, please. Thank you. So the sheriff talked about our STAR program, and Sahan and I are going to kind of move into the nuts and bolts of our medication for assisted treatment program. One of the, just point of clarification, so the STAR program is a peer-run recovery program that people can be in, whether they have opioid use disorder or any kind of substance use disorder. So STAR participants, some are engaged in a MAT protocol, others are not, but they're sort of two different things, if that makes sense. So our MAT program, which I'm going to get into now, it is also a voluntary program. We don't force people to receive treatment. We started in July of 2020. And again, as the sheriff said, as our key response to the opioid epidemic. While this approach for jails across the country tends to be a new approach, the medications that we use are not new at all. So primarily, and I'll get into this in a minute, but we primarily use buprenorphine. That was approved for use in the United States in 2002, not a new medication. Methadone was approved for pain in 1947 and then began to treat opioid use disorder in the early 70s. Again, not new. Naltrexone in 2010. The newer injectable medications, many of you hear about Sublocade and Brixadi. Sublocade was approved in 2017, and we will brag about this just because it's something to say, but we're the first jail in Virginia to start to use Sublocade. Brixadi was just approved in 2023. A little bit about methadone, and I know that was one of the questions, and Sahana will get into this a bit too, but we used to only continue pregnant women on methadone by sending them out for dosing at a hospital. Now, and because I think opioid use disorder has become more at the forefront of people's work, we work very hard if someone comes in on methadone, to work with that treatment program in the community to obtain guest dosing privileges and work collaboratively with the clinic to be able to provide them medications. And it's been outstanding, the work that we've done, or the work that we see being able to continue people. So that's kind of a new thing. Next slide, thank you. So a bit about data, because people like to hear about numbers. So our program started in 2020, and we just had like 1.9% of our population on a treatment protocol. Interestingly, that's not because we had only 1.9% of the population with an opioid use disorder. It's because we were learning how to screen and develop our skills in treating opioid use disorder. Today, between 16 to 20% of our population is being treated with MOUD. I say 16 to 20% because our population changes daily. People come and go. We generally treat about 100 people a day. Usually on weekends. On Monday we have more than well over 100. But as people move in and out of the system, those numbers fluctuate. But around 100. In fiscal year 2023, we treated nearly 1,500 people with MOUD. We screened over 9,869 people, and of those people, 16% of those screened positive for OUD, and of those we screened, 92% of them participated in our treatment protocols. Over the last couple of years, we've treated nearly 3,000 people in our jail for opioid use disorder. And I always like to think that's a really, really big treatment program, just for any kind of treatment program, let alone that we're a jail. But the numbers are staggering, but they've pretty much evened out. So that's a very big snapshot to look at our scale a little bit. We also know that, and for those of you who work in jails, people come and go very quickly. We will walk through for you our protocol and how we begin to look at people at booking. That really has made a difference in how we recognize and treat people. I want to address briefly some of the problems, because it sounds like we do everything right, and we have learned a lot from the errors we've made, and I think it takes a little bit of courage to talk about them, and also recognize that this is what happens when you are working in a jail, starting a new program. So some of the barriers or issues that we face, stigma has been huge. We have had to work really hard at helping our staff, as well as our individuals incarcerated, having a recognition that this is a chronic illness. It's not a behavior. It's not a choice. People with opioid use disorder need treatment, need medical treatment. it's been a big mind shift. Interestingly, for both our confinement staff as well as our medical staff, because we've always looked at addiction as that other problem. Oh, that's what the CSB does. But when we view it with the lens of a chronic illness and managed and prescribed medications from our medical team, it takes on a different light. And we'll talk about that more. We have, and I think for folks on this webinar, we certainly have had issues with diversions, with drugs being sent into the jail. We've had drugs of high value, the buprenorphine has super high value in our jail. And if you have buprenorphine on you, you can do a lot. You can get a lot of benefit on the side. There's a secondary market value to it. But it's not the only medication used in our jail that has that value. With every diversion, we've learned very hard how to correct, how to work together, and how to address problems, and then change our protocols accordingly. I could give an entire 3-hour presentation on all of the issues that we've had, and we'll talk a little bit more about those. Also, as we started using buprenorphine tablet form, we had a lot of medication errors. We're a busy jail, and our medical team our nurses are rushed to administer, and we know as humans, medication errors occur. But we've taken a step back to make sure we're educating people that we have a protocol in place and that we're reducing those errors on an ongoing basis. We talk about every one of them. We have had people with bad attitudes, quite honestly. We've added to people's workloads. It's a different way of doing business, and that's been a challenge. It's just sort of how the world works. And we will talk about some of the strategies. For example, someone saying, well, this isn't on my job description, so we just changed people's position descriptions to be inclusive of that legally. We have shifted some of our approaches to release medication. An example is Sahana will get into this more. I'll let her talk about that coming up. But as we've learned from the errors, we adapt, we make changes, and we adjust. I'll tell you one story that happened. We had a hoarding situation where someone was hoarding medications, which if you work in a jail, it's not allowed to keep medications. And it was discovered, and it was a pretty serious incident. And we had our command group meets about monthly. And of course, this happened the day before that meeting, and everybody knew about it. So we talked about it in that meeting and talked about, gee, it would sure just be easier to close down this program because this is a real security issue, but we're not going to do that because we feel this is our legal mandate to treat people. If you watched last month, you heard from Steve Gordon, from the DOJ attorney, talk about the ADA, interpretation of the ADA law, the act, that this is a requirement that jails need to do this treatment. So we moved forward from there, but we try to openly discuss, we try to address, stigma. We all have stigma within us, and we try to work on that. We have a commitment, and our sheriff has a commitment, that we are not going to stop treating chronic illness just because we've made some human error. And this is a real mindset and a real challenge for the public safety world to have that mindset. But with the sheriff's leadership, we've worked through a lot of those issues. This all has taken a tremendous amount of collaboration across many, many groups in our jail. And I like to believe that our change process has become very exciting. Next slide, please. I think people always like to know what kind of medications you use and what you're doing. So a quick history lesson on our process. We started using the buprenorphine tabs. We found that giving people whole tabs, imagine we're treating about 100 people now a day, the length of time for that to dissolve resulted in a lot of medication errors, not waiting, a lot of diversions. And then we learned about the little strips that are available that look like Listerine strips that dissolve in the mouth. And we're like, this is our answer. Well, we soon discovered that we had just as many diversions using the strips and very creative ways of diverting. If people would put the strip on their cup of water, we gave them various things. While we saw a reduction in med errors, we saw an increase in diversion. So we're like, this isn't working. So, you know, we've met and we talked to a lot of other jails, and now we use buprenorphine tabs, and we crush and administer in that way, which is slightly off label, but evidence exists that it's a really good way to use it. And it has helped us with our diversions very much. We also use Sublocade, which is an injectable form of buprenorphine. There are a lot of benefits to its use, including you only have to administer it monthly. There's a tremendous amount of improved safety and security and staff time. Like many of you across the state, we have huge staff shortages in our jail. And this is administering buprenorphine takes time and it takes extra staffing. So we really love using an injectable buprenorphine. The downside is the expense. What we have done in our jail just recently have changed our policy that if you are caught diverting your medication, after one time, you are offered the injectable form of buprenorphine as a way to continue your treatment so that we can maintain safety and security. With Sublocade, we have administered like 66 doses so far to about 23 patients. I'm sorry, that is an out-of-date stat. We've actually now administered 158 doses to 31 individuals. And the length of time has ranged from 14 consecutive months for one individual prior to being transferred to another jail to just one injection. So the range varies. I hope that made sense to everyone. Everyone always asks, so I'm just going to share it with you. The pricing that we have for using the injectable form is around $1,640. And if you work in the medical branch of a jail and you look at your expenditures for people with HIV or serious heart disease, this is an expensive medication, but it is not the most expensive medication that we have used for some patients. I know that when Dr. Gay presented at the last webinar, he touched on some of these, and we will as well. Just how we've looked at some of the common barriers and some of the attitudes people have, and it really is about stigma around addiction. People saying, treating addiction is not my job. I mentioned before, we've changed people's job descriptions. We require specific trainings for folks, and we'll talk about that a little bit more. We've created medical protocols. We have made treatment of opioid use disorder a chronic care priority in our jail. And that has made it has made treating addiction everyone's job. Another common barrier: as a deputy, my job is safety and security, not observing nurses administering meds. And we have worked hard and had many, many conversations, our sworn and civilian staff, around diversion as a safety and security priority. We have reviewed regularly our standard operating procedures. We engage our sworn officers and leaders to help provide clarification about everyone's roles. And we work very, very closely together as a team to address these issues. Another common barrier that we hear is people who divert their medications should be punished, and their medications should be taken away since they don't need them anyway, since they're not taking them. We have worked really hard at trying to separate what is a disciplinary issue and what is a medical issue. So if somebody is receives some discipline for a behavior in jail, that is through the confinement staff, but it doesn't mean that their medication is being taken from them, because that's a medical issue. So we work really hard to divide those two, the two pathways forward. If an individual diverts medication, it doesn't mean that they will no longer receive medication. It's sort of like if we had someone with diabetes here and they did something naughty, we aren't going to take away their insulin. It's just, that's a mindset shift and steeped in evidence. Next slide. And then some additional stigma reduction, quickly to review, the idea that many of us have, and even if we think we're enlightened, we still have this idea about drug use as a choice, a behavior and a moral failing. We recognize, and the evidence tells us, that OUD is a chronic illness. And the sheriff talked about the chronic illness as a long-term, difficult to treat, reoccurring illness. And we see that in opioid use disorder. And we know that providing this treatment makes our jail healthier, and it makes it safer. And we really know that this is not a choice. The idea that the meds are too expensive and we don't have space. When we started doing this and started planning, we were thinking we needed a new area, or a different area to do inductions, that we would have to be carefully monitoring these individuals as we started them on medications. We thought we needed extra staff, and we quickly learned that we could treat someone with opioid use disorder anywhere they were housed in the jail. That induction is just like starting someone on any other medication. We learned a lot as a lot of our own fears about how to provide this treatment dissipated as we did it. We really try to recognize that, all of our fears and stereotypes, ways to get around them, to move forward and address them. And a lot of it's about personal values clarification that we challenge each other every day. The idea of using MAT medications is just replacing one drug for another. I look at illicit drugs and medication in two different ways, but it's just not the same. But that is a common belief. It's a common belief. It's sort of an old school belief, even in the recovery world. But it's one that we've worked hard to challenge. The other concept of safe withdrawal is good enough. We want people to have a safe withdrawal, and then we can, just give them a dose of medication when they leave the jail. We are really committed to treating people and treating them clinically as long as they want to. The evidence tells us that people may need medications for opioid use disorder for 1 to 3 years or longer. Most of them are not going to be with us in that time, and Sahana will be talking about how we do handoffs into the community. But we know that withdrawing people just is no longer the standard of care, and is no longer a best practice. I personally believe if we have someone in jail for a period of time, what better time to introduce them to this concept of recovery and use of medications to help support their recovery. Again, this is not an exhaustive list. I just wanted to address some of them, and I'm certain that you all in your own work have a long list of these as well, but it's great to talk about and great to be open with everyone in talking about that.
Well, Laura, we had a question that I think is kind of along these lines. One person asked, what motivates diversion? Do inmates who don't have opioid use disorder get high from taking buprenorphine?
No, you would have to take a lot of buprenorphine. So I think there's some motivation, just as a person's addicted mind. There is, if you think about drug use and so forth, there's a certain feeling you get from holding medication, from having it, from having a secret, from keeping it. So that's one piece of it, just sort of the addicted brain. Another piece of it is really around the economy that, of a secondary market for medication in the jail. I hope that makes sense and addressed it.
Thank you. And I also noticed a question about the training program for staff. I think you mentioned that will be addressed in the next session. And I think you've addressed here some of the specific tasks you've undertaken to train staff. in order to change their mindset. So I guess we'll leave that for the next.
Yeah, and we really do try to have ongoing conversations, either one-on-one in roll call, through formal presentations, and we will address that some more because it's an ongoing thing. I think another theme for us is once you launch a program like this and you get kind of good at it, it's easy to be complacent and say, we know what we're doing. And the minute we get complacent is the minute we, start in that stages of change that we relapse, we go back to old behaviors. So it's important to continue on.
Is this a good place to take our break?
Yes. And I think after the break, Sahana will pick it up.
Okay, great. Thank you so much. It's so informative, and I'm sure there are more questions that we'll get to after the break. We are going to take a 10-minute break, and if you have come in since the beginning of the program, we would like you to just take a few moments to complete a brief 5-question participant information survey so we can learn more about who's here on the call today. Also wanted to let everybody know that a couple references were made to our first session that is available, and we'll be including the link to that on our website, both the recording and the slides, as well as a resource page. So we'll take our 10-minute break. We'll be back with you at about 10:20, and hope you can stay on to join us then. Thanks, everyone. Thank you for taking it from here.
Good morning again. My name is Sahana Kapoor, and I will be covering more about the MAT implementation process and our reentry supports to the efforts in order to support our MAT population. So we have categorized our MAT implementation into 4 priorities, one being patient experience, staff experience, partner engagement, and operational efficiencies. So with the patient experience, our focus is on the services that our clients receive, starting with early identification and screening, withdrawal management, medication induction process, and the ongoing treatment that they receive while they're at the Fairfax County Adult Detention Center. So under the staff experience, I'd say leadership endorsement and support is key. Staff engagement and ownership of the program is crucial for any program success, right? And we invest in ongoing educational and training opportunities for our staff so that they feel confident and competent in their skills. Organizational development also includes removing any kind of barriers to implementation, and quick and rapid responses to any kind of identified concerns, and removing barriers is also vital to building the buy-in from your staff. And we do all of this, keeping the safety and security at the forefront of our efforts, but again, not losing the sight of individualized treatment for those getting arrested and coming into our facility. Something that I often reflect upon is anything important done alone? And most often, the answer to that is no. And as you implement MAT program or any kind of program for that instance, don't hesitate to seek out support. In fact, it is important to enlist your stakeholders for help. We have adopted this model. It takes a village kind of an approach, and asking for help, we believe it's a sign of strength, right? And we want the same for our clients as well, right? So it's kind of in a way, role modeling it to our clients as well. Also, we recognize the value of peer support services and how peers are able to engage the individuals who are still in their early stages of recovery. So timely reentry supports are important to assist our individuals with successful transitions into the community. And we partner very closely with our Community Services Board, as well as Chris Atwood Foundation, peer support specialists, and their staff is on site at least 2 to 3 times a week. They recently opened a recovery community center. That's the Chris Atwood Foundation Recovery Community Center that's very close to our jail. And this has been a great resource for our clients who are getting released. It's within walking distance, so it's close proximity, and it makes a huge difference when we can send our clients over there when they get released for support. So we have put a lot of effort into the hot handoffs or the soft handoffs or the clean handoffs, as we say this, to the community services board clinics and providers in the community. We'll talk more about these, seamless transitions into the community providers later. But last but not the least, our fourth and final priority is the operational efficiencies. And here, our focus is on timely and accurate delivery of services and sustaining our efforts in the long term, in the future. We want to ultimately make the process efficient by paying attention to where the handoffs happen, because this is where we call as like slipping through the cracks, right? And we don't want this happening. So the focus is on seamless transitions between the teams, even within the adult detention center when they're still arrested and when they're still receiving services inside the facility, as well as from the point of release to the transition into the community. So in order to do this, sharing information to keep everyone informed is extremely important. And this is kind of like constantly an evolving process. So this is a wonderful quote from Rosalind Carter, and it states, a leader takes people where they want to go. A great leader takes people where they don't necessarily want to go, but ought to be. So strong leadership buy-in and support are important to launching a MAT program, ideally from the sheriff. And I particularly like this quote because, it reflects what you need from your sheriff and your leader. Approach your sheriff with some kind of understanding. I know this kind of like question came up, like, if our CSB is not supporting this, what do we do? So we would say that approach your leader as well as community stakeholders with some understanding of where they are with the change, and think about the stages of change that Laura actually talked about. And if there is a lack of awareness, education, and buy-in is needed before you start the program. Launching a program without your leadership buy-in or support could be somewhat a recipe for disaster. So we want this to be successful in the long term, right? So we want to kind of like educate people and make sure that we're all on the same page when we start this program. If you were at last month's presentation, you heard, Department of Justice Attorney Steve Gordon talking about the mandates for change. This could also be a motivating factor for your sheriff. But for us, we want to do this our way as opposed to having it done to us. And you heard our Sheriff Kincaid talk earlier, and she actively sought our information, and she recognized that we need to move forward with this implementation. And she's a strong believer. And if you hear her talk about this, she says this all the time, this is the right thing to do. So it starts with the leadership, and then it trickles down with the staff where the change management is key. It is important to support the workforce in developing a change mindset. So ask and involve your staff for help and to resolve issues as they arise. Asking for help actually builds support, and this way you can also have the staff buy-in. We here, what we do is often we hold open sessions, meetings, roll call discussions, and consult, about the expected changes. Kind of like help people know when things are actually going to change and what to expect. We have ongoing huddles, just like on the spot sometimes, to resolve anything that may come up in between our regularly scheduled meetings. We also encourage that you develop a strategic plan of like a to-do list, right? And with assignments and due dates. And this has been extremely helpful for us because we are in this process. We are not only able to hold ourselves accountable, but we can also hold our partners accountable in this process. So as mentioned earlier, Laura covered this, Sheriff Kincaid also talked about this. Myth busting and answering questions, any doubts from your staff, addressing stigma. This is not a one and done process. We do this on an ongoing basis. You need to create opportunities for people to ask questions and challenge the processes that we have, right? This is how we can continue to improve. We have also used our grant funds to bring in expert consultants from outside, consultants as outside experts. They have been able to reinforce the messages that we want to be able to share with our staff members. Also consider, sheriff to sheriff non-public conversations, consider MD to MD conversations, nurse to nurse conversations, and so on, because this can also be very helpful. And ultimately, connections and collaborations are key to successful programming. We have connected our prescriber with other prescribers when they have reached out to us. I have connected with the clinicians in other programs, other program managers, be able to share information. And this is how we can help each other out. Otherwise, it can kind of like be, very isolating. And we don't want that to do. And we believe that this is a huge initiative and we want to be able to support each other. So the startup tips and resources, and this slide outlines some tips to consider prior to implementing a program and while you are still in the planning stages, right? And we at the Fairfax ADC require all of our staff to review and sign off the SOP, standard operating procedures and protocols on a regular basis. So we update them and we kind of like, keep it making sure that we are up to standard and know what's going on around us as well. We have patient agreements, which typically lays out the patient requirements, what they need to do and what they can expect while participating in the MAT program. This agreement is reviewed by our providers with each patient when they start the program, and the participants sign this. We have this in our electronic health record, and if anyone's interested, I'm happy to share this, but also others are also available in some of the publications, that was actually shared with the last webinar. So training and education is also extremely important, right? As you implement this, even with the medication administration, we have a medication administration video, we have the tips for medication administration, and it's a joint effort. So know that some medication errors will be learning opportunities, right? But however, any kind of like purposeful, like shortcutting errors are absolutely unacceptable. For example, administering meds through like food slots where you can't like really see if the lights are not like completely turned on, and skipping, crushing the medication, or just like giving this directly. We want to avoid those kind of like purposeful like shortcutting methods. And sometimes, this could happen, especially when numbers are growing. As of this morning, we have 102 individuals on our MAT program, and that's pretty huge. And our jail population is anywhere between like 650 to 670. So this is significant. And when the numbers grow, the resources are not necessarily always growing. But you do have to be mindful of like, how you can support your staff and make sure that the protocols are followed. You have to be mindful and know that successful implementation requires like ongoing reviews and monitoring. Check with your staff to see like, how things are going, reviewing with them, monitoring, and just kind of like, we do this like constantly. On the right side of the slide, you have like two great resources that we'd highly recommend. The first one is for the providers, and the second one is for all staff. The clinical meeting, mentoring for treatment of opioid use disorders, which is the PCSS MOUD resource. It is a free resource. It's a free service, and providers can register for training. They offer one-on-one mentoring with peer mentor who will help them with prescribing practices and also talk about like any specific challenging case reviews and so on. The second resource is particularly my favorite, and it's extremely helpful in educating your staff. It's kind of like the SUD OUD 101, and we'll be sure to share all of these resources with you. So why is MOUD MAT or OUD treatment important, right? Why even start MAT while individuals are in the jail? We get this asked all the time. What's the big deal about the MAT program? From 2007 until 2009, an estimated 58% of state prisoners and 63% of sentenced jail inmates in the United States met the criteria for drug dependence or abuse. These numbers have only grown since then. You can imagine, and since pandemic, these numbers have probably like double, quadrupled. And in recognizing this, we have made a major shift in our practices, and now we screen everybody that's booked into our jail for the opioid use disorder. So we begin with a screening for everyone who is booked into our facility for both alcohol and any kind of like drug use. So positive findings are, automated into our electronic health record system, and we use validated screening protocols or evidence-based practices, NIDA assist, and part of the drug screening includes urine drug screening and a pregnancy test for all female patients. These are new booking practices. So this adds time to the booking intake process because we are asking questions about their current medications, medical history, family history, PREA, PPDs, and all of these other things. But ultimately, it allows for early identification and being able to provide timely treatment. Medications for opioid use disorders in our facility is started at a time when a person begins to become ill or, with the withdrawal, when the withdrawal actually starts. So changing these requirements were not always easy, and it's not going to be easy. And please know that, it can be a frustrating process many times. And with us, you can only imagine how frustrating this might have been to add this to the existing nursing workloads, right? Like we are facing shortage of staffing and resources. So, to add anything additional to what they're doing, sometimes it is burden, but, we understand and recognize this, how it can be increase the workloads, but at the same time, we are committed to using evidence-based practices in all we do and continuously focus on improving our service delivery. So on the right side, this is a picture of our medical intake desk, which is one of the steps of our booking process. And in here, we have a signage which says "We care." And this is an example of the social norms marketing, right where the focus is on focusing the positive messages about healthy behaviors and attitudes. We care. It's not often a message people hear in jail, right? But the shift, the experience from, from something punitive, and we want to make this more welcoming. So we did talk a little bit about the withdrawal protocols, and just a quick recap is our withdrawal protocol starts right after screening, and we identify there is a concern, and we use validated screening tools like clinical opiate withdrawal scale, also called as COWS for OUD, and a clinical institute withdrawal assessment tool, also known as SIVA for the alcohol withdrawals. So having these protocols in place to treat substance use disorders has allowed us to have the uniformity in treatment of our patients, right? Like what they receive, the services that they receive. Protocols also establish a treatment blueprint that guides our nurses in treating patients by giving them guidance as to when to call the prescribers, when to refer them, and all of these other things that they have to do. Also, by using evidence-based assessment tools such as SIVA and COWS, you can minimize the subjectivity. So this can be extremely helpful. So, we know there is less subjectivity and there's more science. That's what we rely on. And we talked a little bit about the patient agreements and involving patients in their own health and future is key to improving self-advocacy, prioritizing personal health, and managing individual chronic illness. And we have a patient-centered approach here and collaborate very closely with our patients, offering them all choices and education about the medications so that they can make an informed decision, right? And when we go to the doctor's office, when I go in, I want to make sure that my prescriber is able to provide me all options and walk me through all of these options, right? And so we always think about like, why should this be any different just because they are in jail? Our medical providers provide the MOUD, and we know that medications for opioid use disorders is highly effective. Individuals, are not mandated to receive counseling or behavioral health services to participate, but it is highly encouraged. And we don't want to make this mandatory because like there is evidence which suggests that, starting medications could be a first step, and then, we could slowly add other supports. So MAT is a voluntary program, just similar to our STAR program. People can choose to leave the program, but we take this very seriously. Anytime when a person actually chooses to discontinue medications, we as a multidisciplinary team from different perspectives, we meet with the individual, talk to them, provide the information, and we use motivational interviewing approaches to increase engagement and motivation to be able to remain in treatment and continue treatment. But at the end of it, if a person chooses not to, we will still find a way to support them, right? Because we ultimately believe that there is multiple pathways to recovery. So I always say this when I meet with patients, and I say, if you don't want to continue treatment right now, if you know that you are getting released, please contact us, let us know, right? Because if they are getting released maybe like a week before, we can always provide them resources and talk about the treatment options as well. So we just let them know the resources and the choices that they have and the option in case they change their mind. Also, we work very closely with our community services board staff, clinical staff, and the peer staff, and they're all fantastic in providing additional services, which all points to stronger outcomes, right? And our team, including providers and the CSB staff with our other stakeholders, Chris Atwood Foundation, we meet weekly to discuss individuals and to collaborate on the patient care. We also have huddles in between, and we have sometimes huddles with the sworn staff with confinement, classification, and those that they not be directly involved in providing the treatment, but this practice allows for multidisciplinary discussions, right? And kind of like coming together to brainstorm and also be able to improve the process that we have and see how we can constantly improve our outcomes. So the weekly meetings have helped us with like rapid process improvements and, making sure that we are looking at any barriers. We are constantly, looking at the challenges and how to break these like barriers and how to make sure that the patient actually has a seamless transition while they're in here and going into the community. So ultimately the focus is on the recovery, and our CSB staff provides clinical counseling, supportive counseling, and they provide education, trauma training, and our peer staff actually meet with the patients, meet with the clients from the peer perspective, and they have a unique value, right, with someone who is already in recovery. So they bring all of these skill sets to be able to, increase that engagement and that motivation while they're in here. The medication administration protocols, our nurses and deputies are trained and closely collaborate on the medication administration process. You see here, there's a nurse and the post deputy who's actually standing side by side and observing the medication administration. And this is part of our SOP. We also have a training video, and if anyone's interested, we are absolutely happy to share that as well. And another thing that makes a huge difference is that our leadership supports our medication administration process by joining the nurses and deputies during the routine administration and follow up with the staff to see if there is anything we can do to improve the process, right? It's the people who are boots on the ground, kind of like checking with them to see how things are going. So it was not all easy as we were working through this process. And I know Laura shared this earlier, right? It was a challenge to get sworn staff to be active participants, because we did hear it's medical team's responsibility. And sometimes you hear medical team saying that, well, it's the sworn staff responsibility. However, this shifted when, some of our command staff, our majors and our captains, they started participating and they promoted this practice. So by shadowing them and talking to them, they actually were actively involved in this process. So, it was helpful in bringing medical and the confinement staff together in this process. Along with these, we have also implemented routine audits to ensure that the protocols and procedures are being followed. And, we encourage staff to hold each other accountable, right? And report any concerns. This is not to, tell on each other. And this applies to all sworn and civilian staff. And I have sometimes staff coming in, sometimes confinement staff and saying that, well, we noticed this. This was not like following the protocol that was laid out in the SOP. So could you please clarify? And this is certainly not punitive. We don't use this as a punitive way to, punish staff members, but as a way or as an opportunity to educate them and train them and, just look at other supports, right? Sometimes people might be having, a tough time, right? And being able to check in with them, it certainly goes a long way. And just seeking support, it's also a sign of strength, as I said, and it certainly goes a long way. So we talked about our wonderful peer services and the peer support specialists that we have, and I do want to highlight the importance of the peer specialists in providing the comprehensive recovery services. So at the Fairfax County Adult Detention Center, we recognize the importance of peer specialists and the value they add as someone with lived experience. So something unique to our jail, and Sheriff Kincaid talked about this earlier, is that we have peers that were formerly incarcerated at our facility return as peer specialists to provide peer support. We have peers from the CSB, Chris Atwood Foundation, and we'll have soon peers working for the sheriff's office as we have, we are in the process of hiring 2 peer positions, certified peer specialists, as well as a recovery navigator to help with our efforts. And this is our way of showing that, putting things into action and saying that we're not just talking the talk, but we're also walking the walk. And similar to other law enforcement agencies, our background process is also quite strict. And passing our background checks, was challenging and can be challenging for a peer specialist who might have had a history of legal involvement, right? And we recognize this. So we have worked with our leadership to review each individual's circumstances and develop a plan to ensure that, safety and security is still upheld. Like, for example, I met with the peer support specialist and I met with our lieutenant colonel, and we kind of talked about the parameters. And, we start off with baby steps. We said the first 3 months, the peer specialist, when they're still being trained, we will escort them throughout the jail. We'll make sure that they follow the policy. And we also have set up meetings with our command staff, to be able to talk about any issues, any concerns, anything. And in addition to all of these, I continuously act as a liaison, and I offer support, ongoing support to, any of our stakeholders and partners that actually are in the jail. So moving on to the reentry support. So we as an agency talk about this all the time. According to the Bureau of Justice Statistics, and this might have been covered in also the first webinar, An estimated 68% of those that are released from the correctional facilities were rearrested within 3 years, and 82% were rearrested within 10 years. So I think this kind of like highlights that when reentry fails, individuals, families, and our communities fail. We at our sheriff's office have prioritized reentry to provide people with the support that they need to successfully return to their communities after their incarceration, and to provide people with, support. And ultimately, this also can improve public safety as well. So we recognize that the risks and needs of individuals returning to their home after their incarceration period are often unique, and we strive to address some of their critical needs through our reentry services. So it's kind of like, it's not a one size fits all. It's, there's no one approach for everybody. It's kind of like tailored based on their unique needs and what exactly they need. We see this as 3 categories, right? Transition preparation, which is preparing for transition, transitioning into the community, and the kinds of support one needs once they are already in the community. So one of the biggest challenges that we have noticed, and also if you read research articles about reentry, it highlights, staying connected once someone gets released is one of the biggest challenges. So in order to address this barrier, we started providing free cell phones. We started thinking about, our HIDA funds. And part of our HIDA funds is actually utilized to purchase like free cell phones. And we also have a Uber account. So with this free cell phone, we provide an iPhone with 1 month of like unlimited service that's activated at the time of the release. And that phone number is shared with the peer support contacts, as well as the community clinics. Providing a phone, many people, when they're arrested and when they're incarcerated, they know that their phones can actually be monitored, right? Any of their phone calls. So we want to make sure that when they get released, they should be able to use their cell phone appropriately, and we don't want this to be a barrier. So we included a note in the phone, and it says, we care about your future and want you to stay connected. Unlike in the jail, we cannot monitor any of your calls. There is no tracking device attached to this phone, and this is to encourage people to use the phone to stay connected with the treatment providers. If people connect with community treatment, they can also get additional minutes that can be added to their phones. So when we purchase phones as well as some phone cards. And I actually share these phone cards with the Community Services Board clinics, where they hold on to this one. And this is used as an incentive. And as you implement or as you move along, you constantly have to think about like incentivizing the program at every step. That's kind of like helpful to help people motivate to stay connected in the program. So essentially, as long as someone is engaged, they get free phone service. And sometimes it could be up to like 4 months, right? Until they're able to be stabilized on treatment, they're able to get a job, we are able to assist with that. We also provide up to 2 weeks worth of like medications upon release, and we pay for these medications. And the hope is that this will allow them time to connect with the community provider once they get released, because many times we see that when someone is getting released, medication, although they have been on medication, that's not at the forefront of their mind. And they want to go back home, they want to be able to see their family, or they are sometimes thinking about like, what do I do next, right? Like, I am out of state, how do I get back home? I don't have any contacts, any supports in the community. So we don't want this to be a barrier. So we want to make sure that we at least provide them with like 2 weeks worth of medications, hoping that this would give them time to settle down, continue the treatment, and there's no breaks in treatment. So recovery housing can also be a challenge, and recovery housing is available for anyone that does not have a stable place to stay. A lot of people, when they're getting released, they say that I don't want to go back to the same place. I now recognize that, that was a place where everyone that I know, or most people that I know, are still using, right? So we want to make sure that that again doesn't become a barrier for them to be in recovery and stabilize. So we also assist with recovery housing, and Chris Atwood Foundation actually helps out with this. Many times we can time very closely depending on when someone is actually getting released. We can time the recovery housing interview, and we can make sure that everything is lined up. Community Services Board provides backpacks with basic needs. We also provide, xylazine test strips and fentanyl test strips as well. I mentioned earlier that CAF now has new peer recovery center within the proximity of the jail, and this allows for like a safe way to continue connecting with supports and building a recovery network. And we know some of our individuals who have actually been released from jail. They have kept in touch with us, and they have gone to the recovery center. They have started volunteering there with their harm reduction van, and being able to participate in the 12-step programs as well. So as I mentioned earlier, we offer bridge dosing, or up to 2 weeks worth of like medications upon release from the jail. And we will fund these, right? We will fund these medications. And we always tell people that you don't have to worry about these medications or paying for this. And once they get connected to the community providers, they can actually take over, even if it's Sublocade. Our community providers with the CSP, they can continue the Sublocade injection once they get released. We offer Narcan and Revive training. This is the opioid overdose reversal kit. And xylazine and fentanyl strips are also available. Again, this is a shift as more and more public safety organizations are investing and supporting the harm reduction approaches. So remember the stages of change that was covered earlier, and not everyone is ready for change, right? But especially most of our population is in very early stages of change, but again, very highly vulnerable to overdose. So it's extremely important to talk about the harm reduction approaches and make this easily accessible, because ultimately our goal is to save lives. So we talked about the challenges, and I think there was also a question, at the time of release, we do offer prescriptions. We have a contract with a local pharmacy at one of the CSB centers, where we can actually send the individuals to pick up the medications. And ideally, we'd like to be able to send at least with 3 days worth of medications on hand, and the rest of it in prescriptions. And we're certainly working on this one. The model kind of like drifted in between just because of some of the shortages with our resources. Stock medications were like easier for staff, and it actually was like cost efficient, but ultimately we do recognize that it's not aligned with the state policy. So we're in the process of acquiring Pyxis dispensing machine, which will result in a move back to the patient-specific medications that we can provide. So ultimately, our goal is to be able to provide at least a handful of like medications at the time of release, and then the rest of it can be, in prescriptions. So I just want to quickly go over this data snapshot before handing it back to Laura. And a successful reentry is vital, not just for the individuals and their families, but also for our communities. And this is certainly in no way a bragging, but at the same time, we are very proud of what we have accomplished and how far we have come. To date, we have provided 347 free cell phones, 195 housing scholarships, a total of 786 Narcan overdose reversal kits, 603 Uber transportations to pick up medications, connecting with providers in the community, going back home, and 729 released prescriptions, and a total of 757 referrals to Fairfax County office-based addiction treatment program. As hard as it is to implement the MOUD services, it's even more challenging to link people to community recovery and treatment services. And I think most of the, trainings and meetings that I'm on, people invariably ask about like the resources, right? One of the questions for Sheriff Kincaid was, Fairfax County has a lot of resources, but, we always have to remember that, the needs are always greater than the resource, right? And even with Fairfax County being like a rich county, we still have like the needs always like surpass the resources that we have. So this is one of our biggest challenges, and we hear this all the time. And we learn from others, and we have adopted like constantly new approaches regularly. We participate in the monthly DOC meetings, and if you are not already part of it, I would highly encourage you to join this group. Mike Fatula, a big shout out to Mike Fatula, who runs the, this DOC monthly MAT meetings. He's the SUD program manager, statewide program manager for the DOC, and this meeting has been a fantastic resource for us. And Dr. Gay at Chesterfield Jail, he's a fantastic resource. And we're also part of SAMHSA regional meetings, and this can also be extremely helpful as you move along. A lot of you, have or may have visited us, and if you certainly have interest, please let us know. One thing we actually love is that we love hosting other sites, because this is, in a way, it's a selfish thing, because it allows us opportunity to exchange ideas and information and learn from each other. We collaborate very closely with our Community Services Board and Chris Atwood Foundation. So as you move along, if you have any questions, please reach out to us. And our Sheriff's Office has expanded the reentry focus, and we have added more positions. We are looking at innovative approaches and ways to enhance our reentry services. So if any of you are interested in sharing your own experiences or learning more about our program, processes, protocols, and anything that you're interested in, if you want to come and visit us, please feel free to connect with us, let us know, and we'll be absolutely happy to accommodate you and share any resources we have. With that, I want to thank you all so much for your time, and I will pass it back to Laura to review the next set of slides.
My apologies for again being the person who doesn't unmute. Thank you, Sahana, for that great presentation. And I learned a lot, and I think it was really helpful. We wanted to touch briefly on, I know everyone always wants to talk about money, and everybody wants to know how to sustain their efforts in addition to starting. So I wanted to talk a little bit about that as we transition to the discussion part of this webinar. So sustaining your efforts, if you look at the bottom of the slide, it's one of my favorite visuals, is looking at what this says. And there are two ways to read this line. It could be opportunity is nowhere, or opportunity is now here. So in looking at starting up any efforts, I want everyone to try to be a now here kind of person. It's where I try to focus. And there are ways to make this happen without $1 million. So the first thing to share is that, grants are out there. You're going to hear next month about the funding available through the Abatement Authority and also some of your localities. Grants are a great way to start something, but they are never going to be a long-term solution for you. So it's important to kind of plan ahead and be thinking, what do I do when this funding runs out? You should always be thinking about how are you going to sustain this program from the beginning of planning, and how do you engage stakeholders in making that happen. It's not a mindset most of us went to school for. And as we're talking about starting a treatment program, using medications, this is also something that we don't sit around and talk about enough. The next bullet will frighten people and irritate you, but money is really not the problem. It's there are funds out there. There are ways to work within your budget, and I'll talk about that now a little bit more. We have made a lot of systems change efforts by piloting things. When we started using Sublocade, we wanted to use it as a pilot, and we used carryover funds from our last, the current budget year into the next cycle that were left over. And we were able to start our pilot in that way to see how it worked out for us. And it's kind of having an experimenter's mindset to test drive things before you go deep into full implementation, and it helps you scale up slowly. Also, it's really important, and you heard from Sahana, all the data that we have, and they're really process measures, right? How many of this, how many of that, who got what? But they mean a lot when you take that data and use it to prove your concept. And also, you heard the sheriff provide a lot of quotes and testimony from individuals who have been in our programs. Having data and having testimony are a beautiful combination to make it real and to show how your services are impacting lives. So thinking about what data you're going to collect, and usually it's data you have, and how you're going to display that and market it. I like to tell people also, you got to be an honest broker. I spent years working in Fairfax County and local government, and I'll talk a little bit more about budget processes, but don't ask for more than you need. Be realistic when you're putting requests out there. Some people say, let's ask for 2 times more than we need and hope we get half of what we ask for, which is really what we want. And I just encourage people to have that mindset of ask for what you need. So with sustainability, sorry, I lost my notes for a minute. Really using evidence-based practices and making data-driven decisions is key. People don't want your good ideas if you can't back it up with research. And that's what we really try to do, because the evidence is out there. In all of this process in starting up, my role has kind of been to bird dog it and troubleshoot, to try to bust down barriers as they're happening, and to take responsibility and give permission for change. And then as you develop success, things keep growing and success builds, and you got to think big about where you're going. So a little bit more about budget. One of the first jobs I ever had when I got out of school, I had this boss. I was a job coach, and he sat me down in his office and he's like, I'm going to teach you the county budget process. And I thought, I'm a job coach. I don't need to know this. And he's like, this is what will help you in your career. And I barely understood what he was talking to me about, but I will say it has helped me tremendously to understand that other side of our operations. So if you work, wherever you work, learn about your budget, learn about your local budget, learn about all the funding streams, and learn about policies. This is, again, not something they teach us in school, but you can use grants to make new things happen, but you got to have a plan to continue it. I am someone who has had to learn how to write proposals. So if you don't know how to write funding proposals, take a class. They're everywhere. Work with the Opioid Abatement Authority. They have mentors who can help you with a proposal. But understanding the budget process at all levels is key. I have, by accident, stumbled into learning about budget, but I make a point of learning, like when I came to work at the sheriff's office, I met with the finance manager and learned about their procurement policies or how we do things, so that I could work closely with them, because I need to work with them to be able to adjust budget and make budget happen. I don't have the authority to do that, but I can ask a lot of questions, and then our command staff can make those decisions. When I talked about how we piloted Sublocade, it was using funds that were unexpended from our budget, moving it into the next fiscal year. We also have a county fiscal department of management and budget. I like to know their processes as well. And then we have a county budget process. But if you don't know your budget leadership, get to know them and learn about all of these things. Also, this is going to sound out there, but learn about the legislative priorities going on in your locality and also at the state level. Many people were going, we can't lobby, we can't do that. And you can't, but you can educate. So as you run into people, you can share that information. And then we talked about the abatement authority. Sahana, you can go to the next one. Thank you. Okay, the other thing I wanted to talk about sustainability is sharing your story. You can do all the great work in the world, but marketing is sort of key. And this is not, again, something that comes naturally to us because most of us are providers or sheriff's office employees or CSB employees. But learning how to market and share your success is really important. And it's really not your personal success, it's your organization's success. This is a picture of Beth Macy, the author. She did Dope Sick, if you saw that. Her most recent book is called Raising Lazarus, and it's about solutions to the opioid epidemic. And she came to Fairfax and spent, the sheriff gave her access to individuals in our jail, to our staff, and she wrote about both the Chris Atwood Foundation peer recovery work and also the efforts going on in our jail. And not to be a shout out, but if you look at the tiny picture in the back behind her, that is the sheriff in there. So, and me, but it's kind of funny. So why am I telling you that? It's great when you get press, and we didn't ask for it. We got lucky and it happened, but use those successes to help legitimize your story. Seek out media coverage. If you have a communications person, work with them about sharing your good work. And it's baby steps. Sharing and educating your stakeholders. But this idea of marketing is key to sustainability. I'll share with you a little story that whenever I'm trying to do something in a changing way, I was with a gentleman who's long retired, but he said, I just figured something out. You repeat the same story every time, but using different words. And so if you can develop an elevator speech for your efforts and what you're doing and repeat it, because it takes human beings a long time to hear things, and sharing about how you are helping address the opioid epidemic is really key, and it's newsworthy. And I hope that makes sense to everyone. It's a little against how we are sort of taught to think, but it's also sort of being a bit of I'll call what I say a shameless huckster, but a bit about sharing the good news of what you're doing or what you're trying to do. The effort can also change people's minds and open doors. We have this huge opioid treatment program in our community, in our jail, which also then we like to try to ripple that out across our community to increase access for people to have treatment in the community as well. Next slide. Oh, thank you. So this is, I really try anytime I talk to groups or individuals, and you'll have access to these slides afterwards. Feel free to use anything. But Dr. Gay used a slide from the don'tlabelus.org in his presentation. We both love this, their marketing efforts, but we can all work to reduce the stigma attached to treating opioid use disorder as a chronic illness in everything we do. So I love this slide because here's sort of a cool looking dude. And he's talking about, my doctor helps me manage my asthma, my acid reflux, and my opioid use disorder. And what I love about this is it's normalizing opioid use disorder treatment as a mainstream primary care issue, which it is. And so I try to encourage people, when you go to your primary care, when you go to your doctor, ask them if they're using buprenorphine. Ask them to consider that, because it's the way that we're going to make changes in our communities. The other call to action area I'd like to encourage people to do is use people first language when you can. Talk about people with OUD versus that addict. These are subtle changes that really can influence people. Share your ideas about this being a chronic illness and help people normalize that concept. Also carry Narcan with you. This is an easy thing anyone can do. Take the training, it takes a very short amount of time, and carry Narcan with you. It can arm you with a way to save lives, but it also prepares you, and it's something community members can do for free. So that's just a little plug for sharing that concept with you as far as sharing information and kind of calls to actions. We wanted to share some of our milestones that we have accomplished since we launched this program in 2020. And this is also about how you can market. We received a NACO award, that's the National Association of Counties, for our MOUD program and the STAR program in 2023. If you're a county entity, you can apply for an award as well, and you have to follow the criteria. But what it does is it adds a national recognition to your work. So start to look around at things like that. If you work for a city, there's also the same organization for cities. Another milestone, the first jail, we talked about this, to use Sublocade. We know it's a great option for jails. It increases our safety and security, and we really believe in this as with our staffing issues, with safety and security, and all of that. The number of people, getting people connected to the community, getting these hot handoffs done is vital. For all the work that happens in a jail, getting people sustaining that effort and removing the ambivalence of getting back to the community and staying engaged is really important. So when we started doing MAT, we had 0 people who made it to the outpatient clinic, 0, after they left jail. This is still a low number, but it's a good number. Now we have about 25% who actually make that connection to the community clinic, and we're working every day to improve that. We also started providing hepatitis C treatment, which wasn't happening in our jail, partially because it's a long-term treatment and our folks aren't always here. But the great thing through collaboration that's happened is now our addiction medicine clinic in the community has started treating for Hep C as well. And there's such a correlation with OUD and Hep C. So the great thing is, if we start someone on a treatment, and we now can cure people's hepatitis C, we have a way to continue it in the community, and that only happens by partnering and talking to people. Next slide, please. Additional sort of bragging, but we in January, just by our good luck and probably our location geographically to the DC area, we hosted a delegation from the US Congress and also the director of the White House Office of National Drug Control Policy to visit our programs. And it was, on a great thing that's newsworthy on one note. So you're putting the word out about the good work you're doing. On another note, it's so valuing for staff to say, wow, this is really hard what we're doing, but look, people are paying attention. So it has win-wins everywhere. We want, you've heard it from us before, we want to welcome you as well. Just reach out and we would love to host you to have a visit and share information. We love the give and take and learning from each other that happens. And mostly, all of our ideas are free, right? We're not in a for-profit mode. So exchanging that information is so helpful, and it helps people get started as well. We did just apply to become a national jail mentor site. We're hoping to do that, where there will be, jail exchanges and visits. So a little more bragging on our sheriff. She is very engaged in our STAR program. She meets with the folks participating in that program regularly. Our services are always evolving. They're not finished. And having that mindset is challenging for some people, that we always want to follow the new technologies and state-of-the-art practices. And we will continue to grow and change as they emerge. This quote from the sheriff, I personally love, and it gets to the why of what we do and the challenges we face. So you can see the picture of the sheriff here and her quote, "This is not the easy way of running a law enforcement agency, but the impact of our programs can be measured through data, awards, and the individual stories from former inmates who share their progress in recovery. We are dedicated to returning people to our community who are healthier and ready to write the next chapter of their lives." And again, this is a mindset shift that we care beyond someone's period of incarceration to really be a contributing community member and to have a great life, right? It's what we wish for everyone. And I just love this quote, and we could not have the sheriff present this because it's a little braggy about her quote. So finally, next slide, please. Please reach out to any of us. I know you'll have availability to receive, you'll get these slides later, but here's our contact information. No question is a silly question, just ask us. And also we will ask you as well. So I want to thank you for being here and staying through this presentation and listening to it. And I think we're going to have time for discussion and questions at this point.
Oh my goodness, thank you so much, Laura, Sahana, and Sheriff Kincaid. What an amazing day of presentations. We do have a few questions, and if you have questions, please put them in the Q&A, and I'm going to leave it up to the three of you to decide who's the best to answer these. First off, do you think that the value of illicit buprenorphine has diminished some since you've been more widely providing therapeutic buprenorphine treatment?
Ask one more time.
Do you think that the value of illicit buprenorphine has diminished since you've been providing therapeutic treatment with buprenorphine?
Sahana, do you have an idea or an opinion about that?
So I think there is more about normalizing MAT, right? And there is more of an effort, like, not just in the correctional facilities, but also outside in the outside communities. And like Laura was saying earlier, in here, I think it's also a little bit of a placebo effect. If I could say that, where people actually are thinking that they might be able to have some desirable effects and get high on those medications, which is not actually true. But we do have treatment protocols. We do follow that. And if someone comes in, if there is a diversion case, we actually talk about that. We review the whole thing. We review the medication administration protocols. So we do all of those things to be able to check and see what exactly is the root cause of this.
I'll just add, I was in a presentation, or I was listening to a webinar recently where there is a jail in New England that actually offers buprenorphine on demand. So you don't have to get screened. You don't have to do anything. They see it as an inexpensive medication that doesn't cause harm. And it will also eliminate the fact that they don't get everyone screened. Not everybody screens. They're not always honest about their use and so forth. I was amazed at that they do that. It's a buprenorphine on demand process, but their costs have not gone up, and it reduces all the issues around diversion. It's fascinating.
Thank you. And does the recovery housing that you're affiliated with, do they permit residents to take medications for opioid use disorder? I know some housing has abstinence-only programs that don't allow residents to take medications.
So we, primarily work with Oxford houses, and how we have funded these scholarships has evolved over time from using grant funds to working with the CSB. They now fund those scholarships, but we have not had an issue with finding housing that won't allow medication. And if you have the mindset and provide the education that this is for a chronic illness, they're not going to say you can't take your high blood pressure medication while living in an Oxford house, I think, or in a recovery housing residence. So, and that's a little bit you know, of some old stigma attached. And I think the world is changing a lot, but we have not had huge issues with that.
Mhm, mhm. Where can people get Narcan training?
So it is widely available in our community, and you could, wherever you're located, you can get this training through our CSB. And if you Google it, you can find a training through the Fairfax Falls Church CSB virtually. Also, our local Chris Atwood Foundation provides training, and you receive, you know, Narcan kits when you complete the training. So I would encourage you to either check out your local health department or your local CSB as a starting place, but it's widely available online.
Are all of your 102 MAT offenders all housed in one pod? I think we've had a couple questions
Oh,
where people are confusing the STAR program with the MAT program. Maybe if you could kind of distinguish between the two.
So STAR is a much smaller group of folks, all with some level of substance use disorders. It can be any kind of alcohol or drug use issue. So you can be a participant in the MAP program and be in the STAR program, but you're not required to be. We, as one of our efforts, so we do have a special housing unit that's about 44 people that we have people who are on a MAP protocol. We tend to house them there as long as there aren't security issues, which we all have, where people can't be in a certain population level. And we did that as a bit of a test drive or an effort to reduce diversions, because when everyone is together receiving the same medication, it's a lot harder to divert. And we restrict access. We have trustees who, you know, inmates who do work in our jail, and we have somewhat restricted access for them coming in. So it's a very sort of closed system. But again, that doesn't house all the people who are on a MAP protocol, if that makes sense. And we were sort of exploring that. Do we want to expand? Do we want to keep it at that? But it's part of our evolution as well.
So we have a few questions related to medication administration. So let's focus on those for a few minutes. The first question is, the Sublocade a good option for jails?
Well, everyone could have a different opinion. I believe it is. And my reasoning is it's an individual only has to make a decision one time a month if they want to continue participating in this program. And as I mentioned, we have a lot of people who are ambivalent, right? One-time decision for a month, one-time administration for a month. So I believe it is a good option. And I think it's really where we're looking in the future from a safety and security perspective, from a staffing perspective. I think each jail has to make that decision for themselves. And I hope that, you know, a statement about pricing, you know, my hope is that as more medications come on the market, there will be pricing, you know, there will be competition in the market. And I think hopefully pricing will adjust.
And do you provide one-time daily dosing? Oh, I'm assuming this is about Suboxone, or 2 times daily.
We do both, but primarily once we have someone stabilized, we try to have them with a one time a day dosing.
And can you talk about your Suboxone induction process?
Well, we follow basically the standard recommendations by every medical, I'm trying to think of the name of a medical organization, but we do have a protocol in place that I'm happy to share. We have worked with a lot of providers who have tons of experience as we've started to kind of learn how to dose. And Sahana mentioned that mentoring group, PCSS, I think that can be very helpful to new providers. But to get to the question, we do have a standard protocol. Prescribing is a very individualized approach, and we have 4 4 different providers, 5 different providers who might be involved in prescribing MOUD. But we have a range, and I'm going to ask Sahana if she knows the specific dosing levels. I can certainly get that to you as we're doing induction. I just don't have it off the top of my head, the milligrams and the amounts.
Sahana, did you have anything to add?
We can certainly connect anybody who's interested with our providers to get more details. I am not a prescriber, so I don't want to, talk about the specifics.
Thank you. What do you do if an inmate needs methadone as their medication for OUD, but is not pregnant, does not have a prescription for methadone prior to incarceration?
So we do have a very good collaboration with the Fairfax Methadone Treatment Center and anyone who's actually coming in. So we do provide all 3 kinds of like MAT medications, right? And methadone is certainly one of them. We work very closely with them, Fairfax Methadone Treatment Center, to be able to, and they are able to offer us the guest dosing. So we want to make sure that someone who comes in on a methadone, there's a lot of like thoughts about switching that person to take Suboxone and why continue on methadone. But we want to make sure that, if that's their choice and we are able to respect their choice and we are able to continue methadone. So we do that, and we've built the relationship and it's pretty good. It's working out well so far. We currently have like 1 individual who is on methadone, and they have been very kind and gracious enough to be able to provide us like once a week, like what they call as a take home dosages, which our staff actually picks up. And then, we are able to give the medications in here.
Thank you.
And for some of the other, in your own communities, there are methadone clinics that will have mobile vans that can come in and treat. So I think for each community, the model might look differently. I also want to add that there's a tremendous amount of movement nationally at looking at the OTP regulations to be a methadone clinic, for jails to be shifting. And I think it's an interesting policy level thing to pay attention to, because a lot of the regulations are around security, which we all certainly have a lot of security. And I think shifting to not make it a special organization that provides something, but by having it available from our providers would be like a natural next step for us. And it would take out kind of the management and hassle that we experience right now.
Does your facility have a protocol for supervised withdrawals off of buprenorphine, methadone, or other MAT authorized by your medical upon incarceration? And if so, which medication do you use?
You're saying withdrawing people when they come in from OUD?
They're asking about supervised withdrawals upon incarceration.
Well, if someone is really ill, we can put them, we have a small infirmary, but our protocol, and we're happy to share it. Our process is, using the withdrawal protocols that Sahana talked to you about. We also use like anti-nausea, pain management. We use medications that help ease the symptoms of withdrawal, in addition to providing the medication, primarily buprenorphine, at the time that is clinically appropriate to treat. So we do help people withdraw, but we our kind of vision is that we continue to treat that person, not just help them with withdrawal. I hope I answered that question.
If someone comes in with a PO, I don't know if that's prescription order, and is put on Sublocade, when they release, will they need to continue the injection, or can they go back on the PO? I am not sure if the treatment centers at my location provide the injection.
I'm not sure what PO means. It could be probation officer or prescription order. So in our community, I can just speak to that.
Right.
And I
She's
think,
speaking by mouth.
okay, I think, I think it's worth exploring in your own community, but we do, and it's interesting because our different partners, we've all influenced each other, as have other jails and the DOC. You know, we've all kind of followed what each other is doing. So our CSB partner, that their outpatient clinic does continue people on Sublocade, and has added that to their menu of options. So we are able to continue it. You know, they are able to continue their treatment in the community.
Okay, thank you. So a question about the STAR program. There's interest in hearing about what type of behavioral management systems, such as pull-ups, push-ups, bookings, sanctions, to hold participants accountable and make them aware of negative behaviors, and if so, how is it implemented with the peers running the programs?
Sahana, do you want me to take it, or do you want to take that?
So we do have pull-ups, push-ups, like, learning experiences. But again, I think like any layperson, like hearing this would sound kind of like very punitive. But again, it's not meant to be punitive, right? Like we have peer mentors on the STAR program who are, who have had a little bit of a foundation in the recovery. And even when it comes to like getting someone new into the program, what we do is it's kind of like a multidisciplinary approach that we have. The peer mentors are part of the team that actually interviews people, and this is to kind of like have their buy-in, right, and be able to meet with people, talk to them one-on-one, and be able to share what the program is, what the expectations look like. And this is to, again, let them know that we are going to hold each other accountable and hold each other responsible for what's going on. So there is a lot of like mechanisms, and the peer support specialists kind of like, guide, oversee, but the program is intended to kind of like, run on its own with guidance and support from the peer support specialists and other program staff.
Can you tell us a little bit more about the components of the STAR program? Like I saw a picture of some folks doing yoga, and imagine there's classroom and counseling and things like that.
So it's a very structured program, right? Like we have like 5 days where peer support specialists are in here and they do programming. They have like living in balance. They have like, AA, NA programs, 12-step programs that's available. We also have a music teacher who's volunteering and who's coming in, and he has started teaching music. And we initially were like, this is something new. Maybe we'll just kind of like try. But he has been such an awesome influence on our individuals that a lot of people have kind of like taken the liking towards music. They are learning the basics about music. And again, music can be very therapeutic, right? Like just like any other form of art. So it can be very therapeutic. So he is also, we have a piano that's locked away, and it's only under the supervision of the deputy that's actually brought outside, that people love learning this piano, learning the instrument. So I think that again, provides people opportunity to open up their minds just outside of like, and be able to access different parts of their brain, right? Like when we're talking about like recovery, it's not just learning about the recovery. Recovery is a holistic approach. That's what we're talking about. So we have our peer support specialists, who actually teach yoga class. So in between classes, and then there is also the MTREM, which focuses primarily on the childhood trauma and connecting those pieces and seeing how the past trauma is impacting them right now, and be able to put those pieces together. And that's, again, I would say it's very well received, because like you have these like really tough guys come in, right? And they're like, oh, I'm fine, I'm not going to cry. And when we start doing this trauma group, a lot of them break down, because many times like we talk about these male messages, right? And we say that, many times people have heard that, oh, you have to be tough, like grow up, like don't be a sissy, like you can't cry. But then we all carry this trauma, and, we have found our way of like coping with things as we move along, but ultimately helping them recognize and realize, is this really effective in this given time?
Thank you for that quick.
So it's a very holistic approach, if I can say that.
Thank you. Earlier question that I keep pushing down the line is, do you have any data on possible reductions in institutional offenses as a result of these programs?
We are collecting that, but we just started, I think about 4 or 5 months ago. So we're building that up till we have a body of data that we can report. Anecdotally, we really believe and we see, when people are receiving medication and they're starting to have some brain healing, they're more aware, they're more cooperative, and less violent. So we, anecdotally, we see a huge difference, but our data isn't quite ready yet for to put it out there, because we just don't have enough months worth.
Here's a question about that transitional reentry efforts. The Center for Medicare and Medicaid Services has a new program that allows an exception to the rule that inmates cannot be on Medicaid for inmates who are about to be released. Are there any efforts to apply for that exception that could help to fund medications for opioid use upon release?
So we do encourage people, we're working hard to get people signed up for Medicaid when eligible prior to release, and they're eligible to apply up to 45 days prior to release, because we would like them to leave with health care. And in my fantasy world, we'd like them to leave with a first appointment scheduled, but that's a little bit of a vision for the future. And I think, nationally, there's a lot of effort, and in Virginia, to do some a waiver to help people obtain Medicaid either 60 or 90 days prior to release to help support that.
And if I may add, any of you who are actually interested in the Sublocade implementation, I know the cost can kind of be very discouraging, right? But please know that the company has a patient assistance program, and they're able to provide up to 3 months worth of free Sublocade for someone post-release. Again, that doesn't help those of us who work in the correctional setting, and there's a huge push for to changing some of that. But if someone does start, in the jail, and when they go and get connected, if they're still waiting for Medicaid to be reinstated, the cost or, that would not be a barrier for them to continue Sublocade injection in the community.
Thank you, Sahana. And I wrote down a note about your bridge clinic program with George Mason University. I wonder if there's a way to do a warm handoff to them or to your other services like the CSB or the recovery housing. How do you facilitate those warm handoffs?
Sahana,
So one of the biggest challenges, right? I think two challenges is continuously comes up. One is the resources and the constraint of the resources. And the other one, especially in the correctional setting in a jail, is how quickly people can get released. A lot of our population is pre-sentenced, and there's no way to say, how long somebody is going to be here. And we are certainly not advocating for people to stay here, right? But if they're here, the longer they're here, it allows us this opportunity to be able to provide them the resources and, put everything in place or put all the ducks in a row. So when we get it takes a village approach again when it comes to our MAT releases. What we do is anyone that is started on our medication for addiction treatment program, we put a hold or a note in our booking card, which kind of an indicator just for the treatment team inside here, which just says yes or no in red, right? Which basically is an indicator to say that this person is on MAT. So when this person is unexpectedly getting released, especially think of a population of 102, and we don't have the staffing to support this 102 population all the time. So if someone were to get released, then we have a booking team who actually lets us know. And, there's an mass email that's sent out to the medical team, our providers, nurses, nursing team lead, as well as the CSB team, Chris Atwood Foundation and the reentry program, which alerts everyone. And then each team is actually responsible for, what they do, right? The prescribers send the prescription, electronic prescription at this time. And the CSB staff actually meets with the individual, provide them the appointment with the addiction medicine clinic in the community for when they get released, and provide them information about how to pick up their prescriptions. And the reentry staff actually coordinates Uber transportation. And when the person calls and says like, hey, can you cab me to my house, we always encourage and we say like, let me quickly check and see. And, it takes maybe like 10 minutes to get to the pharmacy and pick up the medications. Would you be open to that? So we have wonderful staff across the board who kind of like is able to pick up the pieces and, pass it to the next person. This is where it takes a village approach kind of like comes in handy, right? Because we can't do this all by ourselves. And this is where we have like multiple meetings, emails, text messages, and, so on to just make sure. And one thing which has significantly helped us a lot in our releases is Fridays can kind of get really busy for us. So we have on Fridays, Chris Atwood Foundation peer staff is actually down in the booking area. So they meet with the people, talk to them, because face presence, like one-on-one presence, makes a huge difference when you're trying to connect to people rather than, a random business card, right? Which says like, oh, this is some person somewhere in this universe that I have to go and meet. Like, okay, fine. So, we want to make every effort to make sure that we have this one-on-one presence, like before people get released and they know who they have to meet.
We have a question. Oh, go ahead, Laura.
I was just going to add about the George Mason Bridge Clinic. We have had a variety of meetings, and, the goal of connecting with that Bridge Clinic is for folks who are ambivalent, folks who may not be motivated to participate in CSB services, and for those rapid released folks who maybe haven't even become fully engaged in programming. So, kind of the behind the scenes work is how do we get releases of information to release that information to Mason to make those referrals. And so we're constantly trying to do process improvements. And that's something we're working on right now because, we connect with them through a phone call, but we're thinking in some ways it might be helpful if we can find out a way not to violate federal policy in sharing some information with them. We didn't talk about this today, but another component is when someone signs on or agrees to participate in our MAT program, they also sign a release of information that they can choose where the release goes. But it includes George Mason, it includes the Chris Atwood Foundation, it includes the CSB, so that we have the capacity to collaborate and work across systems without violating confidentiality rights.
Great idea. We have two questions about some of your reentry supports, both related to how do you pay for the cell phone program and the Uber ride? Are there grants for that? Is that something that you pick up? And a question.
I can address that just from a budgetary perspective, and then if there's programming, Sahana can address it. But we started, Uber, we just sort of set up that account and used our grant funds, our startup grant funds from HIDA, the Washington Baltimore HIDA office. The same with, what was it, Uber and
Cell phone.
Cell phones, yes. And the cell phone thing was kind of a radical shift for people. And I went through a lot of rigmarole where I had someone checking on it and they talked to our IT department and said, this is not permitted. And it's like, no, I'm not asking permission. I'm asking to pay for it. They're really inexpensive. So we started out with grant funds, and we also purchased a cell phone charger for people who have a cell phone in their property, but the battery is dead, so they can get their phone charged up before they walk out the door. Now, this current year, and this is another reason why you need to work closely with your budget people, they've actually put a line item in our budget, in our local sheriff's office budget, to include that in our direct costs. So it's sort of a sustainability design now where we've moved it into it. And you saw the numbers that Sahana presented about how many we're giving out, and they really are, they look like an iPhone, but they're really sort of burner phones. They're not super highfalutin phones. And I can't remember what we last paid, but I want to say $15 per phone, which some people, it may sound astronomical to do that, but we see it as one more kind of harm reduction approach to keep people in contact. So now we're funding it. We funded with grants, and now we fund with our local budget.
Where did you say you got the phone?
Well, now we have it through our existing county budget, and our budget office they're in charge of managing all expenditures. So they created a line item in the budget where we can bill to now. And I think we have, and remember, we're a large jail. I want to say we have about $25,000 for if we hire an external evaluator for something, to purchase those cell phones and to cover our Uber account. And we really don't spend that much money on it. It's just it's a great service. So the idea of starting with grant funding and then working with your local budget office to sustain it has happened for us.
Such great question.
If anyone's interested in, the whole phone purchasing, like once they figure out the grant funds, or the funding the sources, like we can certainly help, because we do this now once every 4 months, I would say, where we purchase about 60 phones, and then about 30 phone cards.
Wonderful. Well, we're going to wrap it up, and thank you all for the questions, and thank you to our speakers for this fantastic webinar. So much great information and willingness to support those who are on the call and want to take the next steps in implementation. The recording of this session, the handouts, and a resource page will be added to our website. And I believe that link is being put in the chat. And we also, you can find the recording from the first session as well, if you missed that. And just a reminder, if you haven't already registered for our session on April 24th, where we'll be focusing in on the funding questions and with the Virginia Opioid Abatement Authority, Department of Justice, and Bay Rivers Telehealth Alliance speakers. And we would like to ask you to take just a moment before you get on with your day to go to the SurveyMonkey link, which gives us, it's an anonymous survey, which gives us information as we plan future activities and feedback about this workshop. We really appreciate our speakers and all of you for participating today. This has just been a wealth of knowledge and great discussions, and thank you all for being here. If you have any additional questions, you can contact us. And once again, thanks to all who participated: Sahana, Laura, Sheriff Kincaid, and our technical support person, Paris Nelson, and our project manager, Marlene Crawley. We're signing off, giving you a few extra minutes back for your, hopefully a lunch break. Hope you all have a wonderful day, and join us in April for our next part 3 of this important webinar series. Thank you all. Have a great day.